Good afternoon, everyone. My topic for today's presentation is validity techniques, and my moderator is Dr. Sumit Mehta, sir. This is an overview of all of the topics that we will be going through today. First, we will discuss about what is validity. Then we will talk about the techniques for improving generalized recall, strategy, strategies for avoiding miscommunication, techniques designed to help us raise a sensitive or taboo topic without disengaging the patient, and techniques for carefully exploring a sensitive area once it has been raised. Now, first, what is validity? Now, validity, it refers to conformity with truth or a gold standard that can stand for truth. The validity techniques, it may be divided into techniques for improving generalized recall, strategies for avoiding miscommunication, the techniques designed to help us raise a sensitive or taboo topic without disengaging the patient, and techniques for carefully exploring a sensitive area once it has been raised. Now, the first technique for improving generalized recall are anchor questions. Anchor questions, they may be time related or they may be location related. The anchor questions, which are focused upon time, they are based on the fact that people tend to remember significant distant events in relation to other memorable events that were happening in their lives or in their culture near the moment of the memory being recalled. Like a person, he might be better able to tell us that something happened, not with the question as when did you first begin drinking, but with a question like, did you begin drinking before or after you started high school? Like this, a variety of events, they can be used to help people pinpoint the timing of recalled events more effectively, including personal events like marriage or any major cultural events or cultural markers. Second is anchor questions, which is focused on location. Now, this will be used if the patient is about to describe a specific event that occurred, a dissociated event, a panic attack, a suicide attempt, an act of domestic violence, that one fears it may be distorted or repressed. Now, our goal will be to maximize the validity of the reporting by ensuring that the patient is picturing a specific memory and it is not just a blurred collection of similar memories. Now, if the patient, he can revisit a specific memory bank, the hope is that as they relive that specific memory, more and more details of that memory will come back. Now, for this, we may ask several questions in a row about the details of where the patient was when the experience occurred. Now, with dissociated memories or in violent memories, we should only use these techniques if we feel that it is very important to uncover certain details and that patient can safely, in a psychological sense, revisit those memories at that moment. Next is tagging questions. Now, tagging questions are cueing a patient's memory about a concrete topic from a list that the patient is having trouble recalling, even though that topic is not a sensitive one. For example, a patient may have trouble remembering a specific medication he or she has been on, a type of psychotherapy that has been used, or the name of a therapist. For example, if you have a patient and he says that I can't remember what medication I was on, we can ask him that, do you remember what it was called? It was called Petrol, it was called Zappis. We can ask these questions. Next is exaggeration. Now, this is a technique for immediately decreasing a patient's inordinate shame, so as to increase the likelihood that he or she will continue to share sensitive material while simultaneously securing engagement. Now, in this sense, this type of the technique of exaggeration is not only a validity technique, it is an effective engagement technique. Now, this works by helping the patient understand that when his or her shameful activity is put into perspective with other types of human wrongdoings, the patient's activity is not of great magnitude, and highlighting the fact that we as an interviewer, we are far from aghast as at the patient's revelation. Now, second type of validity technique is for avoiding miscommunication. Now, sometimes a term is frequently used by both professionals and the lay public, like depression and addiction, and not always in the same way. Now, it's easy to slip these words into a conversation and not realize that they are being misinterpreted. Now, for example, we have many patients who are experiencing psychotic symptoms, and their family members come to us and they say that that depression है patient को. So now a common problem will arise when exploring sensitive or taboo topics in which the culture in general or the patient's family in particular has taken a traditionally enabling stance. Now, many clinicians, they ask patient questions such as, have you ever been sexually abused by someone? And they receive a convincing no, when in reality, there has been substantial abuse. And this happens because the patient grew up in a family where psychological, physical, and or sexually abusive behavior was the norm. And the patient herself or himself has no idea that what happened to her was actually abuse. And now for this, a strategy called clarifying norms may be used, in which we ask the patient specific questions about whatever happened, so that the patient herself or himself realizes that what had happened. Third type of validity technique is for raising a sensitive or taboo topic. In this first type is normalization. In this, the interviewer phrases the question so that the patient realizes that he or she is not the only one who has ever experienced the behaviors or problems under scrutiny. Now, this type of technique will particularly be useful if we have a patient who is very guilt-ridden or is filled with social anxiety that they are doing something bad or they are doing something odd. Now, for this, we begin the question by stating or implying that we have heard this behavior from others and that the patient is not alone in having experienced these feelings or behaviors. So, normalization, they often begin with words such as sometimes people who have. Like sometimes people who are worried about gaining weight, they sometimes induce vomit after eating meals. Or this is also very much useful in patients of suicidal tendencies, that patients who have these thoughts, they sometimes think about hurting themselves. Next is shame attenuation. Now, first type of shame attenuation is used to bridge from pain or situational stress. Now, in this, the patient's own pain or situational stress is used as gateway to sensitive topics such as suicide or psychotic process. Like we can ask patient questions like, with all of your pain, have you been having any thoughts of killing yourself? Or with all of the pain that you have been having, are your thoughts ever so intense that they sound almost like a voice to you? Second type of shame attenuation is used to uncover aggressive, unethical, or antisocial behaviors. Now, in this, we cue off a patient's distorted view of reality, which is caused by common everyday defense mechanisms. Now, the basic premise of this form of shame attenuation is that if we can figure out the patient's rationalizations for why he or she is doing something, and we ask the question from the perspective of the patient's own rationalizations, perhaps the patient may be more than likely to answer openly. Now, in this, we do not validate this behavior, but we meta communicate that we understand how people can fall into such a behavior. Next, we have an interview for which I request Dr. Mankaran and Nikhil to please come. Here the clinician is interviewing a patient, and the clinician feels that the patient is not telling the truth. A patient is hiding the fact. A patient himself does not realize. ऐसे बहुत सही है आपकी इससे बहुत मछली और बस पीछे पड़े रहते हैं कि आदत So in this interview, we started from the patient saying that he had no problem with his jobs, and we ended with the patient himself saying that he has been fired from his job around 5 times. Next is induction to bragging. Now, in its simplest form, we attach a positive adjective to a behavior with a negative association. So we begin with a complimentary statement, which makes it easier for the patient to almost brag about a behavior that is somewhat less than exemplary. Like we can ask the patient that you are very much well built, so you must be a good fighter. So for this, and next the patient, he himself will say that he has been in fights or not. Next is validity techniques for exploring a sensitive topic once it has been raised. The first type in this is behavioral incident. Now, whenever we are particularly concerned about gaining accurate information, it is often best to ask the patient to describe specific historical details as opposed to asking the patient his or her opinions about these details. Now, once a patient is asked to give an opinion, the validity of the data becomes more suspect because we do not know how accurate the patient's perceptions are. Now, this discrete historical behaviors elicited are called as behavioral incidents. There are two types of behavioral incidents. In the first type, which is your fact-finding behavioral incident, we ask for a specific and concrete bit of behavioral information or a train of thought. Like, did you load the gun? Or what thoughts were going through your mind at that moment? In the second type, which is your sequencing behavioral incidents, we simply ask the patient to chronologically unfold the story with questions such as what happened next, or right after your friend accused you of lying, what was the very next thing you said to me? Next, we will describe two interviews. In the first, the clinician asks the patient, uh, in the clinician asks patient opinion questions, and in the second one, behavioral incidents are used. I again request Dr. Mankaran and Dr. Nitin to come. In the next interview, Next, next is a topic which is called making a verbal video. Now, in cognitive behavioral therapies, this process is often called a chain analysis. Now, when making a verbal video, we interweave a series of fact-finding and sequencing behavioral incidents that prompt the patient to create a verbal walkthrough of what happened. And if done well, the clinician should be able to see exactly what happened in his or her own mind, allowing him or her to better evaluate the extent of action taken towards suicide by the patient or the degree of violence involved in act of domestic violence. Now, in this, if the patient suddenly skips ahead, creating a gap in the verbal video, which are called as Nixon gaps, the interviewer simply rewinds the video by asking the patient to go back to where the gap began and prompts the story to restart from there with more behavioral incidents. Now, the limitations of behavioral incidents are that this form of questioning is very time consuming, and also the great utility of behavioral incident does not mean that patient opinion questions are not useful, because they are invaluable for understanding the patient's perspectives, needs, opinions, and goals. And they also allow us to naturalistically observe the patient's defenses, and they provide the foundation for collaborative problem solving. Next technique is gentle assumption. Now, in this technique, the clinician, using a gentle tone of voice and non-accusatory wording, assumes that a suspected behavior is occurring. Now, this meta communicates the reassuring message to the patient that the clinician has already encountered this behavior in other patients. Now, this type of gentle assumptions, they should not be used with patients who feel compelled to please the interviewer, like a patient with histrionic or markedly dependent personality disorder, or those people who might feel intimidated by the interview, like a child or a patient with limited intelligence. Because in such cases, it may lead to a patient reporting something that is not true for the feel that they are supposed to have the experience or behavior in questions. Next is denial of the specific. Now, in this, the clinician asks about specific items from a theoretical list, such as a list of potentially abused street drugs or a list of potential suicide methods. Now, this type of technique is used directly after a patient has responded with a not very believable no to a gentle assumption. Like, for example, if a patient said none after being asked, what other ways have you thought of killing yourself? And the clinician suspects that the patient is hiding something. Now the clinician might ask, are you having any thoughts of hanging yourself? If the patient admits to such thoughts, the extent of planning and action taken on hanging would be explored by creating a verbal video with behavioral incidents. And if the patient answers negatively, we proceed to the next method, which we suspect the patient may be withholding. Like, have you been having any thoughts of shooting yourself? Now, in this technique, it is important to frame each denial of specific as a separate question, pause between each inquiry, and wait for the patient's denial or admission before asking the next question. We should not combine several inquiries into a single question, like, have you thought of shooting yourself or overdosing or hanging yourself or jumping off a bridge? Now, this series of items combined in this way is called a canon question. Now, this will frequently lead to invalid information because patient only hears parts of them, or they may only respond to one item in the string, and which is often the last one. Next is catch-all question. Now, this will often be used after a string of denials of the specific, if the clinician is suspicious that an odd outlier may have been missed. Now, with patients in which one remains suspicious or we feel that an important or rather unusual method of suicide has been with him, we can ask the patient that we've talked about a lot of different ways in which you've been thinking of killing yourself. And is there any method that you've thought of, even briefly, that we haven't talked about? Now, this question can also prompt the patient to share that he or she has done a web search on suicide, offering further glimpses of the patient's intent. Next is symptom amplification. Now, this is based on the fact that patients sometimes downplay the frequency or degree to which they have indulged in disturbing behaviors, such as the amount that they drink or the frequency with which they gamble. Now, with this technique, we allow the patient to naturalistically use minimization as a defense. Now, we will accomplish this by setting the upper limits of quantity in question at such a high level that when the patient will downplay the amount, the clinician is still aware that there is a significant problem. And this technique should only be used if we are suspicious that the patient is going to minimize. We can ask questions like, how many physical fights have you had in your whole life? 30, 40, 50. And or on your very worst days, when you are thinking most about suicide, how many hours do you spend thinking about it? 8 hours, 12 hours, 15 hours. Next, we will talk about malingering. Now, one of the best assets for spotting malingering is a detailed knowledge of what symptoms are present in what diagnosis, and how these symptoms appear when really present, and what the pain is like that people feel when these real symptoms are present. Now, with this, we can carefully weigh what the potential malingerer is describing with what patients coping with the real things actually experience. For this, there is a technique called endorsement of bogus symptoms. Now, in this, we ask the patient if he or she is experiencing a symptom which we know that it is highly atypical for the disorder being seen. And if the patient endorses having such a symptom, the likelihood of malingering goes up. Like, for example, we have a malingerer who says that he hears voices. We can ask questions like, do your voices often slip under the door? Or do your voices tend to slam into the back of your head? To be effective for eliciting malinger response. Other questions are that whenever you have your panic attacks, do they tend to stay with you for many hours on it? Or during your most severe periods of depression, do you usually find that you wake up feeling pretty good, but as the day progresses, the depression becomes so devastating that it is frankly hard for you to function despite your best efforts. And usually we can use 2 or 3 of such bogus symptoms so that the likelihood of malingering, if the patient is malingering, we will have. Next is gauging motivation. Now, Haven's technique, which is called as soundings, is an example of an interviewing strategy not designed to increase motivation, but to accurately determine its current level. Although it is often used to determine a patient's motivation to proceed with beneficial activities that may be hard to do, as with following therapeutic recommendations, it can also be utilized to determine activities best not done. Like, for example, we have a patient who presents to us with a delusion that he is being constantly watched by his neighbor, who he thinks might be plotting to poison him. Now, the following series of soundings, we can decide the level of conviction the patient has regarding his delusion, a concept which is called how much distance a patient has from his delusion. Like, you may sometimes wonder, can this really be true about your neighbor? Or do you feel that there's too much evidence to doubt it? Or there doesn't seem any doubt at all in your mind at this point? And we will pause after each of these soundings to see how the patient responds, both verbally and non-verbally. These are my references. Thank you.